are so happy you have decided to join us. I have the distinct honor and pleasure to introduce you today to Dr. Landovitz, who's going to talk to us about what we have learned and where we go in terms of COVID-19. Just a reminder, this is a medical tract presentation, so there is continuing education credits available. You will need to fill out an evaluation at the end, and we will provide you with that link. As you can see here, there are no conflicts of interest from any of the speakers or coordinators for this presentation today. And Dr. Landovitz, you are good to go.
Thank you so much, Megan. I really appreciate it. So, hi everyone. I'm Raphael Landovitz. For those of you that I haven't met, I'm an adult infectious disease physician at UCLA, and I've been a volunteer at Vermont's Camp Tecumseh for 28 years. So that's how I come to COCA. And I'm going to be talking today about some updates on COVID, sort of where we are and where we're going. Let me see if I can share my screen here. Can people sort of see this okay?
Yes, it looks good.
Okay, perfect. So we're 2 years into the COVID-19 pandemic, and I'm going to be talking today about what we've learned and what we still need to know. So I'm going to be doing some updates on where we are with COVID right now, where we are with prevention strategies and vaccines, where we are with treatments, and then I'm going to pull out my crystal ball or my magic 8 ball and try and make some predictions for the future. And full disclosure, I have no idea what's going to happen. So I just want that pretty clear. Those of you who know me, and I do see some Camp TKT folks in the Zoom. So hi, folks. Would expect me no less to begin a talk that I'm doing with a joke. So here's a joke. Did you know that Yoda had a last name? Lehihu. Get it? Say that together. Okay. Please don't block me. Anyway, okay. So let's talk. Thank you, Dina. Dina's laughing. Excellent. So the last time I presented to a COCA medical town hall, I think was in June. And at that point, we had some pretty grim statistics of over 160 million cases of COVID globally, over about 3.5 million deaths. And we sort of knew the geographies that were most affected. In the US, almost 35 million cases and 600,000 deaths. I wish I could say that the numbers look better now, but they don't. Globally, we're up to 250 million cases and over 5 million deaths. And of course, in the US, we're approaching 50 million cases and over 750,000 deaths. And no sign of this really abating. We're currently on the downtrend, and we'll talk about that and where I think things are likely to be going. So sorry to start on a little bit of a bitter, sour note, but I think we all can agree that the past 18 months have really been batshit crazy, and there's really no other word that describes sort of how it's been. This is sort of how things have looked since the beginning of the pandemic in terms of the geography of where cases have been spiking and most contributed to. And you can sort of see based on the colors, and North America is in orange, that the relative contribution of cases in North America, and this is overwhelmingly in the US, have gone up and down in terms of the contribution. And you can see sort of in the July to October of this year time period towards the right side of this slide, where that was our fourth wave, that was the Delta variant. And you see it coming down towards the beginning of October. And what's a little scary, and we'll talk more about this, is the overall numbers look like they're starting to go back up again. And, I don't want to be Debbie Downer, but let's keep that in mind as we talk more about what's happening. So that was infections. This is deaths. It's a little bit of a similar kind of plot. And again, you can see the US is sort of that grayish brown color, the contribution to the overall number of deaths due to COVID across the world. The US is the larger portion of that gray period, the gray bar across. And again, although we don't see it quite going back up in terms of deaths in the US yet, you can sort of see overall what is happening to the right side of the slide, with the numbers seeming to have hit a low point and then are starting to go back up again. And that's largely due to what's happening in Europe. And again, we'll come back to that and sort of how in the past, if you remember, our whole fourth wave with Delta probably should have been something that we could have predicted by keeping a close eye on what was happening in India earlier this year. And it sort of given us a little bit of an insight into what we were in for. And I'm a little bit afraid that we haven't learned that lesson particularly well. And what's happening in Europe now is something we really need to keep our eyes on in terms of what we may be facing this winter and early into next year. But more about that later. So let's talk about the US in particular. And, you know, as I'm sure you all know, any presentation on COVID, by the time you actually make it, your slides are already out of date completely. And so, you know, when I pulled these slides together about a week ago, these are already old data, but you can see, you know, what's gone on with this fourth Delta wave over here in the United States, and that, it seemed like things are coming better and better and better. But I would ask you to just keep a really close eye on what's going here towards the end of October, beginning of November. And there's a question of, are we seeing a little bit of an uptick again? And, you know, you can see overall, the numbers of cases by state in the map on the right. This isn't adjusted for when the cases happen. Just, the darker blue colors are the states that have had the most cases overall. And I'm sure each of you is looking at your own state to see how your state has fared in terms of overall numbers of infections compared to the other states in the country. But I don't think it's a surprise to anybody where the most highly affected states have been thus far. Okay, so this is something that actually something that I keep a very close eye on, and this is available on the CDC website. And this is the local levels of community transmission by county. So this is county level data. And you can see that you don't want to be in the red areas, because coming out of the red areas is going to ultimately what is going to make local public health departments say that we can stop masking restrictions because community transmission is decreasing. And so you want to be seeing your county turning orange and then yellow and ultimately blue. And those will all be signs of us making progress in terms of local community spread. And this, of course, can change on a moment's notice. But this is actually the most current data. And I sort of surf onto this website that's on the bottom of this slide every couple of days and just sort of see what's going on. And, I particularly keep an eye on where I live here in Los Angeles, which recently turned orange. And so that was a good thing. And we're all kind of excited about that. And hopefully, if that trend continues, our requirements for indoor masking, even for vaccinated people, might be relaxed. And that's really what's governing the CDC's guidance. And so there's a lot of confusion about what the instructions are for people who are fully vaccinated wearing masks in indoor spaces. And the CDC is pretty clear about it. Basically, if your county's in a red area, you should be masking indoors, even if you're fully vaccinated, because the rate of community transmission is that high. And I think that's really underappreciated by people. People are like, CDC is not telling us we have to. They kind of are. They're just not calling out individual regions. They're asking you to do your own sort of digging to figure out if your area is affected by that. So I think that's something that's underappreciated. And another reason that I would encourage you to take a peek at your county, your local area on this map, or if you're planning on traveling somewhere, to take a look at this map. And, regardless what people are doing locally, this is actually the best guidance. And I'll share with you, I was in New York City all last week, and I hadn't been there in 2 years, and ain't nobody wearing masks indoors in New York City unless specific businesses or venues are requiring it. And I was like, is there even a pandemic going on? Does anybody even pay attention to this. It was a little odd. I didn't quite know what to do with it. Again, screenshot this map, or you can, we'll distribute the slides and note that website. It's a really good one to keep your eyes on. So, a lot of people are wondering what's going on Delta, right? Delta, that's the variant that caused this fourth wave. And if you look sort of since July to Halloween time, you can see that what's on the left side of this slide, this B.1.617.2, that's might as well be a foreign language, but that's Delta. And it is overwhelmingly the strain, the variant that is circulating here in the US. There's really not a whole lot of anything else. Delta has taken over the world, and that's probably because it's more transmissible than all the other variants we've seen. So it outcompetes. Think of it like a marathon race. It outruns all the other variants. So that's what you see as the predominant variant. And I think something that we need to keep an eye on is that it's a slightly different variant that is actually causing this spike in Europe right now. It's called Delta Plus right now. We'll talk more about it a little bit later. It's unclear how it's going to compete in a race against just straight up Delta. And it's unclear if it causes worse disease or makes people sicker. But the fact that Europe already had a wave of Delta and now they're having Delta Plus as a separate wave makes me a little concerned that it may compete pretty well in a foot race against Delta. And again, I think it's something we need to keep our fingers on the pulse of and see what's going on. So a lot of people ask me, what's this about Delta? Do we have to worry about Mu? Do we have to worry about Lambda? What's going on with all that? At least in the US right now, there's very, very little, if any, Lambda or Mu. At least in South America, it seems like Delta outruns both Lambda and Mu. So I will be shocked if we get a wave that's attributable to Lambda or Mu here in the US. Delta Plus, I don't know. But Lambda and Mu, I know some of the infotainment sites, and I use that phrase because half the time I'm not sure what's news and what's attempting to be sensationalist. And that's one of the biggest challenges I think we have with getting accurate information. Loves to sensationalize, oh my God, we're going to have Mu, we're going to have Lambda. And it's not at all clear that any of that is going to be a reality. So our best fight against all of these variants are vaccines. And I'm sure we can have a really robust discussion about vaccines. But the bottom line is vaccines are our way out of this pandemic. There are 8 approved vaccines for full use somewhere in the world, not all here in the US. And there have been 10 vaccines that have been abandoned because they didn't work in clinical trials. You can see on the bottom of this slide the various vaccine types and where they're approved. I think the ones that we've talked about most and we're going to continue to talk about are the ones that either have full approval or emergency use authorization here in the US, which is Pfizer, Moderna, and Janssen, or the Johnson & Johnson vaccine. Those are the same terms in case people are getting confused. And we'll talk more about them in just a second. So in terms of where we're getting with vaccine coverage, this is data that's reported to the CDC, and this is as of earlier this week. This is as of November 4th. And you can see broken down by race ethnicity group how we're doing in terms of, on the left side, getting at least 1 dose into people, and then people who are quote unquote fully vaccinated. And I want to just note that that does not include booster shots. Fully vaccinated is considered 2 shots of either Pfizer or Moderna, or 1 shot of the Johnson & Johnson vaccine. So this is just that. We'll talk more about boosters in a little bit. But you can see that, we're just, sort of in the 50% range, slightly higher for some race ethnicity groups. in terms of our vaccine coverage. And if we're gonna stop this pandemic, we need to be much higher than that. No one knows exactly how high we need to be, but the current thinking is it has to be somewhere probably north of 85% of the population fully vaccinated if we're really going to get control over this. Just so you know, nobody knows the answer to that because of waning immunity, because of different sensitivity of the various strains. But it's clear that until we convince people that they need to go through with getting themselves vaccinated, we're not going to be able to sort of end this, what's sort of seemingly an endless cycle of these ongoing waves. So if you want to look a little bit more granularly in terms of by sex, who's getting at least one dose and who's fully vaccinated, you know, let's be honest, you know, the women always get it before the men do. They understand the importance, and so they're beating the men in terms of their uptake of vaccination. So guys, get with it. So in terms of by age, here you could see again on the left side, one dose versus fully vaccinated. The good news is we're doing better in people who are older. And of course, people under the age of 12 just recently would have had their first opportunity to get any of the vaccines with just the regulatory emergency use authorization for the Pfizer vaccine in 5 to 11-year-olds just this past week. But you can see as you get younger, we're doing less well. And what's really clear is in countries who are seeing this so-called fifth wave, including in Europe, it's children, it's young people who are driving the epidemic. Early on, we had this notion that kids either didn't get it or it was very mild disease in kids and they weren't likely to spread. We now understand that that's not correct. Kids do get it, kids do spread it, kids do spread it more efficiently actually than adults. And while it may be true that overall their rate of hospitalization and severe outcomes is lower than in older adults, that doesn't mean that there can't be bad outcomes. And I think we're all aware that the pediatric wards were overrun in these past few months with really sick kids from COVID. And the bottom line is you don't want this viral infection if it's possible to avoid it. Even a mild or asymptomatic case of this, we do not know the long-term medical consequences of it. It's clear that it accelerates atherosclerosis in blood vessels, and we do not know the long-term implications of even a mild case of this viral infection. Kids do get long COVID. You do not want to have prolonged symptoms. There was a study in adults that actually shows that getting COVID lowers your IQ. I'm not making this up. This is for real. They did neurocognitive testing on adults longitudinally, and clearly, probably because of vascular effects, you lose IQ points. So you do not want this, this viral infection if you can avoid it. If you sort of look in terms of what's happening in cases, in terms of percentages of people being vaccinated by age group, what you can clearly see is the better the vaccine coverage, the less disease there is. And that's really important because some people are really frustrated that we hear all about these breakthrough cases, and no vaccine is perfect. This vaccine is never going to be perfect against protecting you against infection. You would like to be fully protected. Like I said, you don't want to get this viral infection, but if you're going to get it, you want it to be as mild a case as possible, and you want to minimize your infectiousness to others. And that's what the vaccine seems to do. So more vaccine coverage, less disease, certainly less hospitalization, certainly less death. And that's this second slide here, reduced death in people based on vaccine coverage. So, you know, a lot of people like to say things that are sort of shrouded in misinformation, that people who are vaccinated are more likely to get COVID than people who are vaccinated. And that's simply not true. And what you can see here is the case rate on the top half of this slide. So this is any infection. The proportion of times higher the case rate is in people who are unvaccinated compared to those who are vaccinated. So it's anywhere between about 5 and 15 times higher for people who are unvaccinated than for people who are vaccinated. And the death rate, it's even more of a stark difference. It's basically 15 to 20-fold higher for people who are unvaccinated compared to people who are vaccinated. And these are rates. So this is adjusted for the number of people, which you can really get tripped up by if you just look at absolute numbers. This is the statistically and epidemiologically correct way to look at this comparison. So knowledge is power. That's why I'm showing you these data. If people tell you, look, there are more people who are getting X, Y, and Z, they need to look at the rates of infection and the rates of death and the rates of hospitalization. And when you compare those, there is no question the vaccines are effective for both. If you look at what's happening in unvaccinated versus fully vaccinated people by age, you can see even in very young people, these stark differences in the case rates by age. You know, it's really profound in 12 to 17, 18 to 29, 30 to 49, 50 to 64. You can see it's really powerful. Immunity does, and vaccine response does tend to be a little bit less robust when you're older, which is why there are the smaller differences in the older age groups. If you look at deaths, again, you can see these really stark differences that are more profound in older people because their chance of having a death event is higher if they get COVID. You're really not seeing splays or differences in the younger age groups because the overall death rates are just lower. If you were to expand these graphs with a microscope, you would still be able to see a difference, but it's a much smaller absolute difference. And these are the same scale across all these age groups to show you those important differences, particularly for people who are older. A lot of people want to know what the differences are and how that compares to no vaccine for the different vaccines that we have approvals for here in the US. So here you go. So you can see the unvaccinated people, cases on the top, deaths on the bottom. In gray, the scales are different, obviously, for cases and deaths, but these are all rates, so it's the appropriate epidemiologic or statistical method to look at this. And then what you can see fairly consistently is Moderna performs the best, closely followed by Pfizer, and then J&J does a little bit less well than the mRNA vaccines. And a lot of people say to me, are you surprised? At the beginning, we thought Pfizer and Moderna were basically interchangeable. And I guess in retrospect, we shouldn't be surprised because although they're not the same vaccine, Pfizer and Moderna, they're essentially the same product, but at different doses. So the Pfizer is a 30 microgram dose, and the Moderna full dose vaccine is 100 micrograms of essentially the same product. There are, of course, differences. There are proprietary differences between them. But in terms of the active component, that's a true statement. So the Moderna vaccine is basically 3 1/3 times the dose of Pfizer. So you might say, well, why wouldn't I then go and get Moderna? And the answer is there's a lot more side effects with Moderna than with Pfizer. And the question is, are those differences clinically meaningful between the two? And you know, we're just getting additional data about the longevity of the protection of each of those. And it seems like Moderna protection lasts longer with a primary vaccine series than does Pfizer. Whether that's actually meaningful now that we're doing boosters or not, we don't know. Full disclosure, I got Pfizer. I got boosted with Pfizer. Am I going to go out and get Moderna? No. I had plenty enough side effects with Pfizer, and I'm good with that. And I think probably with the boosters, that's fine. The J&J product, I think it's pretty clear based on the data that's come out. We thought it was originally a one-shot vaccine. It isn't. It really should have been a two-shot vaccine all along. So, there's now data for a second dose of J&J for those people who got it. But there's also data, and I'll show you these data in a second, that you actually get a better response if your second dose after a first J&J is actually with one of the mRNA vaccines. You actually get a better immune response if that's called heterologous dosing as opposed to homologous dosing, which means the same vaccine multiple times. Heterologous dosing means you got a different vaccine for a later shot than the one you got as part of your primary series. But the take-home message that I think you can see from this slide is all three of them, the case rates and the death rates are so much better than people who are completely unvaccinated, and that's really important. So if you don't have a choice and you only can get one of the vaccines, doesn't matter which one, get whatever's available, and then you can always get boosted with something else later. So this is sort of from an Instagram account that I follow. If you don't follow it, I suggest you do. The Instagram handle's at the bottom of the slide. It's Unbiased SciPod. It's two PhD epidemiologists, biostatisticians, public health experts, and they do these amazing infographics every time there's an advance in COVID therapeutics, prevention, data. They distill it down in an unbiased way and make these infographics, and I love them. They're brilliant, they're spot on, and they don't take bullshit from anybody. They get trolled all the time, and it's amazing the way they come back at people. They're really impressive. And they put this together, and this is what I'm going to ask you to take a look at are sort of the bottom three rows of this table. Okay, so they're looking at the three major vaccines that are available in the US, and they're looking at the proportion of people in this group of patients they were following who were vaccinated fully with each of these vaccines, people who tested positive, right? So you can see the test positive rates, and then you see below that the effectiveness at preventing somebody from getting hospitalized, basically in the short term, and then in the bottom row in the long term. And you can see what the rates of hospitalization are. Protection against hospitalization from Moderna, 93% early, 91% late, so that's really good. Pfizer, 88% early, drops to 77% late. Remember, this is without boosting. And J&J, 71% upfront. We don't have enough long-term data to know late, but most people think that there's new data now that may suggest it drops to about 50% or even lower. So stay tuned for more about that. But go follow Unbiased SciPod if you don't already. This is the data that I was just mentioning. This is the most recent information. This is in a preprint. You can see in blue what's happening with the Janssen. This is basically the effectiveness at preventing anybody from turning PCR positive. And you can see what happens out further from a J&J vaccine. Initial levels of high levels of efficacy kind of goes away completely by 6 months later, whereas Moderna and Pfizer tend to retain a lot of their activity. Moderna slightly better than Pfizer. Again, these are without boosters, so that's really important. And these are just the same way of looking at this, except this is breaking it down by age. And on the left side, infection overall, and on the right side, breaking it down by age in terms of death. So not surprisingly, they're comparing age over 65 versus younger groups. You can see older people do less well with all of the vaccines. It's more profound with the Janssen vaccine, but this is true of all of the vaccines. All of the efficacy attenuates over time. And it was basically based on these data that the authorizations for boosting were derived. And that's why we really think that everyone's going to need a booster, at least one. The Moderna and Pfizer 6 months after the initial series, and the J&J at least 2 months after that initial vaccination. So, as an adult infectious disease physician, this is have all been sort of the Super Bowl for us. We sort of trained our whole careers for a pandemic, but nobody wished this on us. And so even though so some days I wake up and I say, I hate my job, I'm sort of like this toothbrush, and at least I'm not the Johnny Brush bowl for the toilet. Um, so I have to keep that perspective, and at least, this is something that I feel like educating people about and talking about is something that's really important. And, you could argue that there may not be a whole lot more important for us to pay attention to right now. So let's talk about boosters just for a second. I mentioned already the Pfizer and Moderna. It's 6 months after your initial dose series. For J&J, it's 2 months after that first dose. You can see who's eligible by the current CDC guidelines. I will tell you that a lot of people consider these soft indications, and I know people who don't meet these criteria who have gone in and successfully gotten boosting. Do I think that that's where the whole field is heading? Is everyone needing boosters? Yes, I do. Is it technically legal to do that? No, it is not. Am I recommending that people who don't meet these criteria do it? Not officially, no, I am not. And you can see at the bottom what the booster options are depending on what your initial series is. Basically, if you got Pfizer or Moderna, pick your poison. You can have any one of the three. And same thing with the J&J. I'll be honest, if it were me, I would go with a Pfizer or Moderna booster regardless of what you got up front. For people who really want the absolute highest level of immune response, I would probably go with a Moderna booster, but you're doing that at the expense of more side effects compared to the Pfizer booster. The Moderna booster is about 1.5 times the Pfizer dose. It's not the full original Moderna dose of 100 micrograms. The Moderna booster is 50 micrograms. The Pfizer and J&J boosters are the same dose as the initial series was. So this is on what basis I'm saying that. This is a super sexy little chart that I keep in my phone when people ask me what the relative antibody responses are when you get a booster shot. So if you look, for example, on the left side, if you look at Pfizer, right, if you got a 2-shot dose of Pfizer up front and then you get boosted, your third dose with Pfizer, you get antibody levels that are about 15 times what they were before you got the booster. If you got Moderna, it's 17 times. Is that 15 versus 17 clinically meaningful? I don't know. I honestly don't think so. But if you want, quote unquote, the best antibody response, that's what you would do. And you could see how J&J compares. Same sort of profile with if you got Moderna up front, you can see that if you sort of mix and match and you get Pfizer as your booster, you actually get a slightly higher immune response compared to if you got your third dose with Moderna, and certainly better than J&J. Is that clinically meaningful? I don't know. But with J&J, you can sort of see really clearly what happens. And this is why I'm saying if you got a J&J up front, I would get an mRNA booster. If you get a second J&J, you get about 5 times your antibody level. But look what happens if you get Pfizer or Moderna. We're talking 30 to 60 times more antibody. And antibody levels, while not the entirety of the immune response, there's a whole other arm of the immune system that this doesn't account for. This does correlate tightly with both infection protection and protection against hospitalization and death. So you do want higher antibody levels. So again, screenshot this, keep it, use it, or we'll distribute the slides and you can have it. But I find this very helpful. How are we doing with booster shots? You can see the in sort of the mustard yellow here, what's happened since September. We had a huge jump sort of at the beginning of October, and now we're sort of hitting sort of an exponential increase, and that's all really good. But what is really concerning is we're not getting to the people who never got their primary vaccine series in the first place. And that is going to be what's going to get us out of this pandemic. The boosters are great, and they're going to it's a little bit like preaching to the choir. They're going to keep people protected who already buy into that vaccines are an important part of protection, but they're not getting to the people who need it the most, who are the people who, for lack of a better word, and I apologize for the religious reference here, who are the non-believers. And we need to find a way to get people to understand why this is important, not just for their own health, but for the health of everybody around them. And that's the bottom line. So, this is sort of how I approach a lot of my social gatherings. Will you hang out with me? Will you do X with me? Will you be my Valentine? I don't know. Have you been vaccinated? Oh, there's that one again. I clearly like that a lot. How are we doing globally? This is a huge deal because, we live in a global community, and this gets back to what we were talking about at the very beginning about keeping an eye on what's going on in Europe right now. All you have to do is, get on an airplane somewhere, and whatever is happening in Europe is all of a sudden happening in the United States. And we saw what happened with Delta as it originated with the Indian fourth wave or second wave, actually. And then it spread across the world like wildfire. So air travel makes it possible for these variants that happen in other parts of the world to immediately disseminate like wildfire. So we really cannot just pay attention to what's going on here in the United States. So very much this issue of what's happening with vaccination all over the rest of the world is very much our problem. Not only is it a moral, ethical obligation for equity for people across the world, but the reality is we are not going to be done with this until we have this pandemic controlled all over the world, because all it takes is one plane flight. And you can see what's happening. Just look at the African continent. The levels of vaccination in the overwhelming majority of the African continent is essentially negligible. And until we get high levels of vaccination uptake across the world, we are not going to get ahead of this. So, this is fully vaccinated. First was one vaccine dose, and this is, boosting. And you can see, we're not even, even on the map in a lot of the countries with regards to boosters, but that's because we haven't even gotten primary vaccination doses into the majority of the world. So let me just switch to a second about treatment. Where are we with treatment? So as of today, we have one FDA approved treatment, and it's called remdesivir. It's intravenous only. It's for people who are hospitalized only. You can't use it in outpatients. And it's kind of weak. It's a little bit like Tamiflu for influenza. You have to start it early in the course of infection, and it doesn't really do a whole lot. So there's not a lot of excitement about that. There's 7 other treatments that have either emergency use authorizations or approvals for other things. So people do use them. Some of them are the monoclonal antibodies that are available for both inpatient and outpatient use. And then there's steroids for people who are hospitalized and have oxygen requirements, as well as other supportive interventions like ventilator support. But I want to draw your attention to the upper right sort of greenish box. There are 4 interventions that are super promising. Some of them are anti-inflammatory medications that for people who get really, really sick with COVID that we think is driven by an sort of volcanic eruption of the immune system. There are some immune suppressive medications, baricitinib and tocilizumab. But I want to talk for a second about molnupiravir, which is this Merck oral drug, which is going to be going before the FDA, because as a pill combination, it's 5 days of pills. It's 40 pills total. So that's 4 pills twice a day for 5 days. It reduced the risk of hospitalization by 50%, 50%, in people who are at higher risk of complications. So this is, again, an unbiased SciPod graphic that talks a little bit about this Merck drug. So it's going to go before the FDA for emergency use authorization the end of this month. So we could see it in pharmacies as soon as by Thanksgiving time. And it's sort of interesting. It's a
It's the
pill-based.
COCA conference.
Like
Say
it's
again?
old, or it's going on right now?
Oh, sorry. I thought somebody was asking a question. So this drug has one big problem, and that it's a mutagen. So it does alter DNA. People get all crazy that messenger RNA vaccinations are going to alter their DNA. It doesn't. But this drug, it does. So whether or not it's going to be able to be used in kids or in pregnant women is a big question. But if you have a medication that is available as a pill and could be administered as an outpatient that reduces hospitalization by 50%, I think that could be very powerful, particularly if it's disseminated all over the world. What will be really interesting is to try and figure out if it actually reduces infectiousness. So not only are you treating yourself, could you reduce your ability to infect others? And we don't know the answer to that yet. But the hottest news, and this is again, hot off the press as of last week, is Pfizer, not to be outdone by Merck, of course, has an oral drug too. And it's only 30 pills over 5 days. So it's 3 pills twice a day, 6 pills a day for 5 days. And it reduced hospitalization in people who had COVID by 90%. So that's sexy. And it is not a mutagen. So it doesn't alter your DNA. And it's got this really sexy name, Paxlovid. Get it? I don't. But anyway, that's what they're calling it. It does have a lot of interactions with other medications, but they're also going to go for emergency use authorization. So stay tuned for that. So you might say to me, well, with 90% protection against hospitalization from the Pfizer pill and 50% with the Merck pill, why would you ever take the Merck pill? Good question. If I were Merck, I'd be asking that question also. The other thing that I wanted to mention is there's some really provocative data, if you want to talk about recycled old drugs, about this antidepressant called fluvoxamine. There was a randomized trial with people who had COVID, and they were at increased risk of progression of their disease. And this medication reduced the risk of death from COVID, which is really ultimately what you care about. It reduced hospitalization also by about 70%, but it reduced death. And the other 2 pills haven't been shown to reduce death. So this is something that's super exciting. It's got a much more well-characterized safety profile. It's available now. It's cheap. And the question is, should we be using it more? And I don't have the answer to that question. You might notice that I said nothing about ivermectin or hydroxychloroquine. That's because they don't work. Full stop, period, end of discussion. A lot of people wonder if masks work and why we require people to use masks. And the answer is yes. And the most definitive data we have comes from a study from Bangladesh. Yes, Bangladesh. And what they were able to show is when they randomized various communities to either universal masking or not, just sort of standard masking requirement, they were able to show dramatic reductions in people getting COVID in the people who are using universal masking. It was by more than half. So the bottom line is, yes, masks work. They are not going to be 100% protective, but if you think of it as slices of Swiss cheese all lined up, and nothing is ever going to be perfect. Everything has holes in it, like a slice of Swiss cheese. If you keep lining up various slices of Swiss cheese, eventually you're going to have a solid block where the holes don't go all the way through. And that's what you want. You want to sort of knock transmission using multiple approaches down to 0. So we could talk forever about whether there should be mask mandates in schools. You can see on this slide where they are or not mandated and where mandates for mask use are banned. We won't even have a conversation about that. You can see the mask policies by state on this slide. And I think I mentioned earlier, there's this thing called multisystem inflammatory syndrome that happens in some kids who get COVID, which can be life-threatening and sort of like this volcanic eruption of the immune system response. And you can see the timing of when we've had spikes of it during the pandemic that have been reported by the CDC. And it's not as uncommon as I think a lot of people would have us believe. It does happen, and you don't want your kid to get it. You don't want your patient to get it. And I think it's something we really need to be aware of. This is not a benign disease in kids. You don't want it, no matter what your age is, if you can avoid it. A lot of people have asked me, but what's with the formulation change for the Pfizer vaccine? Pfizer did change its preservative, its vehicle that the vaccine is in for its age 5 to 11 population. It changed it for something called PBS, or phosphate buffered saline, to something called tris sucrose. This should not be a concern. It's just to increase the stability of the vaccine. It does not change its efficacy. It does not have additional allergens. It's not something that should be a concern to anybody. The efficacy in ages 5 to 11 seems to be 90.7% at preventing COVID symptomatic disease. We don't have data yet in immune-compromised children. Those data are still being collected. Obviously, that's something that, for oncology camps is really critical information for us to have. But for kids who do have non-compromised immune systems, the efficacy, again, this is early, we don't know how quickly it's going to wane in kids, is over 90%, at least with the Pfizer vaccine. And we're anticipating data from Moderna that's going to be more concrete soon. So in closing, what do I want to leave you with? Everyone's like, so what does the future hold? And all I can tell you is, ever since COVID, every prediction that I have made has been wrong. So I don't know. I don't know what the answer is to the future, but here's my uh-oh. And I sort of alluded to this at the beginning. And this is the Delta Plus variant in the United Kingdom in specific. And this is true of all the countries in Europe now. This has sort of spread. But if you see, in June and July, there was very little of this Delta Plus variant floating around. It was, this, 0.1% of the infections. But if you see what's happened through the fall, as recently as the end of last week, it's now up around 12% of the infections in the United Kingdom and other locations in Europe. And what's really scary is this is exactly how Delta looked before it swept across the world like wildfire. So when we look forward to the next summer's camping season, believe me, I am the most optimistic person in the world, and I want to say we will find a way to go forward and do this safely as in person. But this makes me concerned that even before we get there, we may be facing another wave. I hope I'm wrong. I don't know. No one knows for sure. But this is something that we really need to keep our eyes on. I don't know the vaccine efficacy against this Delta Plus variant. I don't know the activity of any of these medications against Delta Plus variant. The bottom line is we don't know a whole lot about it yet because it's so new. So, to the people who say, I'm not getting vaccinated, I'm not interested in vaccination, you can't make me get vaccinated. People say, I don't want to be part of the vaccine experiment. My response to them is, bro, you are already. You're just in the control group. And that's who's driving this pandemic. We need to get more people vaccinated. Stop there, and I'm happy to answer any questions. Really appreciate you sticking with me for 45 long minutes.
All right, thank you very much. I don't see any questions in the chat right now. Oh, wait. Karen from Camp TKT asked you, do patients with severe COVID have an increase in amputations, and if so, why?
So thanks, Karen. I don't actually know if there's an increase in amputations. We've certainly heard anecdotal reports of people requiring amputations, but it's usually in the setting of catastrophic illness from this sort of volcanic eruption of the immune system when people are severely ill, and there are increased thrombotic events. Some of those do lead to the need for amputations when there's gangrene or irreversible limb starvation from oxygen as a result of the clots that form in that sort of setting. But I haven't actually seen specific data on amputations. It may be there, I just haven't seen it.
Let's see. Beth from Beads of Courage asked you, can kids get the flu and COVID vaccine together on the same day?
Yeah, great question. And the answer is absolutely yes. Immunologically, there is no reason not to. There are data now that you don't reduce the potency of either vaccine when they're given together. The only reason some people do recommend splitting them is that so, you have fewer side effects, because some people do get side effects from the flu vaccine and a lot of people get side effects from the COVID vaccine. So, if you add them together, it could be quite a whopper of side effect response. But in terms of them working, there's no reason to not do it on the same day. So if somebody, for example, has traveled a long distance and you're not going to get them back in any time soon, I would go ahead and do them both in the same day.
Don asked you, do you think that eventually we will be receiving annual shots for COVID, much like the flu shot?
Yeah, thanks, Don. Again, my magic 8 ball, when I shake it, says ask again later. But if I were gonna guess, I would say yes. I think what we know about coronavirus immunity in general is that it wanes fairly quickly. And I do think it's going to end up being a little bit like the flu vaccine, where we look at what the variants that are circulating at a given time across the world are, and we try and create a booster that may be tailored to those circulating strains. They are also working on what's called a pan-coronavirus vaccine that would not rely so much on what different strain it is. It would attack all coronaviruses. And if they're able to do that, then they wouldn't maybe need to adjust it every year, but that wouldn't necessarily mean that you don't need to get boosters. It's really interesting. The other arm of the immunity, other than antibodies, right, is the cellular immunity component to it. And we don't yet really fully understand whether what seems to be these long-lived, what are called memory cells, memory B cells that seem to maintain their anti-COVID activity, if those have a role in long-term protection, right? The clinical observation is the further you are away from your initial vaccine series, the more likely you are to get COVID. So it doesn't seem to be protective, at least with the initial series. We don't fully know why, but the rapidity with which the science has evolved in the last 18 months is staggering. And who knows what we'll have learned 6 months from now. So the one thing I ask you all to bear with me about is, I promise what I've told you today is true today. It may be proven false tomorrow or next week or next month, but I promise you it's true today.
Let's see. Susie from Camp One Step asked you, do you recommend requiring COVID vaccines to attend in-person camps?
I do.
All right. Any other questions out there? If you want to come off mute and ask them or type them in the chat, that's fine too. Otherwise, I would like to thank you, Dr. Landovitz. It has been an absolutely wonderful presentation. I know I've taken a number of things out of it. Personally, I think really paying attention to the CDC community transmission rates. And I thought it was interesting that you can lose IQ points after COVID. That to me was just, interesting. You talk about it. Somebody who works in healthcare myself, we've seen this. I work in the cardiology aspect of it, so I see a lot of the thrombotic side of it and whatnot. So thank you very much for your thoughts and information for us.
Sure,
and don't forget, this is a CE presentation. We have posted that link for you guys as well. I will post it again. Make sure that you fill out that evaluation so that you can get your CE credits.
Thanks, everyone. And if you have additional questions, you can email me or tweet me or whatever people do for social media.